up when we're ready to get the webinar going. All set? Okay. Well, welcome everyone. So thrilled to have you here today for our 2024 Robert L. Kane Memorial Lecture, our fifth Robert L. Kane Memorial Lecture. So thrilled to have people here with us in person as well as so many of you online. So thank you very much. Very, very excited for this year's lecture, which I think you're going to find exciting and thrilling and inspirational as well. Always like to start with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. I acknowledge with gratitude the land itself and the people. I take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. I really wanted to thank those who made this year's lecture possible. Primarily Ashley Millenbaugh. Ashley is the Robert L. Kane coordinator. She does so much work behind the scenes in terms of promoting the event, creating social media graphics, arranging sponsors, working through AV issues, which hopefully have been worked through. She's done a great job here. And so again, just so appreciate all of Ashley's work and effort. And by the way, my name is Joe Gogler. I am the Robert L. Kane Endowed Chair in Long-Term Care and Aging. And again, both Ashley and I are thrilled to be hosting this event again this year. Also, a really big thank you to our sponsors, Huntington Bank, Care Providers of Minnesota, Ebenezer, and a special highlight to Episcopal Homes. Episcopal Homes was kind enough to arrange a tour of some of their innovative residential care models this morning with this year's lecturer, Dr. Zimmerman. And we're going to be hearing a lot more about their unique and exciting approach to residential care later in the presentation. So again, thank you to all of the sponsors. Again, we couldn't hold this lecture without your help. I always like starting this presentation with just a really brief overview. What is the chair and what is it designed to do? Many of you knew the original founder of the Long-Term Care on Aging. It was originally called the Minnesota Long-Term Care Chair on Aging, and it was really started and envisioned by Robert L. Kane. Dr. Kane, of course, was a pioneer in health services research and geriatrics. He held this chair from 1990 until his untimely passing in 2017. Like many of you, I counted Bob both as a mentor and colleague for many years, a real giant in the field of long-term care. And the mission of the current chair is really to carry on this immense legacy, to advance scientific excellence in long-term care as well as aging, and to shape the practice, policy, and pedagogy of this critical area of focus in our discipline. So again, I encourage everyone, please do visit us at the website here on the slide to learn more about the Robert L. Kane Endowed Chair. And in the end, the way I see the chair, the way many of us see the chair, is really as a catalyst to build aging-specific initiatives, both here as well as across the university. I mean, we're all in this together. And certainly if the chair's resources can be used to leverage the work we do both within the university as well as with our partners, then I would think the vision of the chair is certainly well on its way to being achieved. So the chair itself sponsors a couple of different events, prominently the Robert L. Kane Memorial Lecture each year, which is really designed to highlight pioneers in the space of aging and long-term care science, those that have achieved both national and international recognition. And as you'll see shortly, this year's Robert L. Kane Memorial Lecture is no exception. We also utilize chair funds to support a very exciting community education conference each year, the Caring for People with Memory Loss Conference, which also is conducted with support from the Health Resources and Services Administration. We also host the Long-Term Care and Aging United with, really it's the Robert L. Kane Scholarship Program now. And this program seeds and supports 3 to 4 students each year who are then connected with a community partner to conduct an internship throughout the course of the year. Very, very exciting work, very community engaged work that has been of great benefit to both the scholarship winners as well as with our partners themselves. And then also we also host what is called the Robert L. Kane Postdoctoral Fellowship. Our current Robert L. Kane Postdoctoral Fellow is Dana Urbanski, who recently received her PhD in Speech, Language, and Hearing Sciences. here at the University of Minnesota and will hold the record as likely our shortest postdoc in history. So she joined us in May and she just got a faculty position at the University of Tennessee Health Sciences Center, which will begin August 1st, but we'll still take credit for her. So thank you so much, Dana. Just wanted to show this real briefly. We very much understand and value the fact that the Robert L. Kane Chair really exists in a very complex ecosystem of aging, science, and scholarship and practice here at the University of Minnesota. And again, time will not permit us to go through all of these different entities. But again, the way the chair is envisioned is it exists to support all of this work, primarily through the Center for Healthy Aging and Innovation, which again is the successor to the original Center on Aging that Dr. Kane directed from 1994 to 2017, as well as many, many other entities related to aging. And again, our goal is to bring us all together vis-a-vis this very well, again, if you could please consider contributing to the long-term care chair, we can continue doing what we're doing. So this is the first year, and again, I give a lot of credit to Ashley for doing this, where we are offering continuing professional development credits as part of the Robert L. Kane Memorial Lecture. And one of the things I have to provide to you is a disclosure statement. So the National Center Office of Interprofessional Continuing Professional Development is the jointly accredited provider for this event, and we comply with ACCME standards for integrity and independence in accredited continuing education. There are no conflicts of interest or financial relationships with ineligible companies related to the activity. To claim CE credits, individuals will need to complete the evaluation form shared at the end of the lecture. So again, thank you very much. And again, there are no conflicts of interest to disclose as part of this presentation. Now, finally, let me turn to the reason why we're here. I am so thrilled and privileged to introduce a great scholar in long-term care and aging that many of us would acknowledge, but someone, and I really meant it when I've said this over the years, really one of my favorite people in this field that we work in aging and gerontology and long-term care, and that's Dr. Sheryl Zimmerman, someone who I've so deeply respected over the years, someone who has worked and certainly who Dr. Bob Kane and Dr. Rosalie Kane knew and worked with as well, and someone who is just really, to me, epitomizes who we look for the Robert L. Kane Memorial Lecture each year. Dr. Zimmerman is a distinguished professor of social work and public health and is also co-director of the program on aging, chronic illness, and long-term care in the Cecil G. Shepp Center for Health Services Research at the University of North Carolina at Chapel Hill. Dr. Zimmerman is also executive director of the National Center for Excellence in Assisted Living. Dr. Zimmerman is internationally recognized as a leader in long-term care research and pragmatic and clinical trials. She's emeritus editor-in-chief and senior associate editor of the Journal of the American Medical Directors Association. I had the privilege to work as a senior associate editor when both Dr. Zimmerman and Dr. Phil Sloan were the editors of the journal, and I learned so much about how to craft science and support science that has practical impact in the field of long-term care. In 1996, Dr. Zimmerman founded the Collaborative Studies of Long-Term Care, the largest ongoing research consortium of almost 1,500 nursing homes and assisted living communities that have participated in more than 70 projects with continuous funding. So please join me in thanking and welcoming Dr. Zimmerman, our 2024 Robert L. Kane Memorial Lecturer. Thanks so much, Sheryl.
Wow. Joe, thank you. I mean, those, in any field in which we work, just having that kind of regard from peers, people that you respect so highly is very meaningful, Joe. Thank you very much. And thank you, and to the rest of you here in person. I've had a terrific visit, getting to know more of the work that's being done across the state, which is beyond impressive. All the linkages, all the connections that all of you are doing, all the impact that you're having. this is a model. You've done a lot of things that I know I'm going to help spread around to other states as well and continue learning from. So thank you. And needless to say, also, I am beyond honored to be able to present the Robert L. Kane Memorial Lecture. Those of you who knew Dr. Kane know that he was among one of the first people to really push us to think about what we need to do about innovating long-term care. He wrote a landmark book that was called "It Shouldn't Be This Way: The Failure of Long-Term Care." That was written over 2 decades ago. And in it, he talked about things like inadequate care, poor communication, lack of coordination of care. Unfortunately, those things haven't changed. So today I'm going to be talking about the greenhouse nursing homes, which is more than a promising innovation. I will be presenting an overview of what the model is and providing some of the research evidence, and then going to be joined by what I think you might find the most compelling part of what you're here for today is first Melissa Schneider, who is the COO of one of the local greenhouse homes in your own backyard here. And hear what it's really like running a greenhouse home and the experiences that they've had on the ground. And then Susan Ryan, who's the CEO of the Center for Innovation, which houses the greenhouse home, the greenhouse model, the greenhouse project that began the whole thing. And I really never want to give a talk about greenhouse homes without Susan being part of that, because she's got the national landscape. She's got the personal stories. She's the one really spreading the model. And then one other reason I was reflecting on why this was the appropriate topic to present here today, not just in memory of Bob Kane's work, but also research on the greenhouse home started with researchers here. Lois Cutler is here today, and it was some of the groundbreaking work that you and Rosalie did that really got this on the map. So to me, when I was offered and invited to speak, it was just the right thing to be talking about. So thank you for being here, and I expect many people online know of a lot of the previous work that's been done. Okay, actually, before I go right to that background, let me start just by making one other point. You know, many of us, when we're talking in the work we're doing within long-term care or whatever the field is, it's almost like we're thinking more about the society. We're doing this for societal good. This is more than societal good. This is personal good. Every one of you in this room, if you'll look to your right and to your left, see those 2 people, and you on Zoom, look to the people on your right and on your left. 1 out of every 3 of you is going to be in a nursing home. So we're not just talking about wanting to have our society have better nursing home and long-term care in that way. We're talking about the care that's going to be affecting us and our family members. So not only had Dr. Kane been talking about the need to innovate and the challenges with nursing home care, but back in 1975, the U.S. Senate Special Committee on Aging called out, and these are quotes, obviously, the dread and despair associated with nursing home care. And then in 2022, which is now almost getting 50 years later, the National Academies of Sciences, Engineering, and Medicine, which just recently wrote a new report, referred to nursing homes as the invisible social ill, leaving you to wonder what the heck has been going on in the last 50 years if we're still talking the way now that we were 50 years ago. Well, the good news is some progress has been made. The notable example, which is obviously what we're talking about today, is the greenhouse small-scale nursing homes. I will talk about the core values of those nursing homes. And today, I at least wanted to get the numbers there. I know Susan will circle back to them. Today, there are 401 greenhouse homes across 35 states and 8 in South Australia. The real question is, though, why aren't there more? And hopefully by the end of today, and with all the new information that people have and the advocacy around this work, we can really continue and have it be so that 50 years from now, no one's going to want to dust off these slides and just add one more bullet about that. Really, in large part, this whole idea about innovation and changing nursing homes grew out of the culture change movement. And of the presentation, I'm describing greenhouse homes research practice and the national landscape. So this grew out of the greenhouse movement, which the culture change movement was started in nursing homes at the end of the 1990s. And that was all about addressing the dread and despair by improving resident quality of life and quality of care, by emphasizing the deinstitutionalization of nursing home culture and focusing on person-centered care. And in other words, to make nursing homes more welcoming and make living there more growth-inducing. And that largely happens through focusing on resident direction, home environment, close relationships, staff empowerment, collaborative decision-making, and systematic ongoing quality improvement. Today, what we're talking about is the key exemplar, and it really is the key exemplar, the broad exemplar of culture change in nursing homes, which is the Greenhouse Project, with the tagline you see there being meaningful transformation that creates lives worth living. First, helpful. Why are they called nursing homes or greenhouse homes? They're called greenhouse homes. They build on the Eden alternative. Greenhouses nurture plants. A greenhouse home nurtures people. Now, how does this do it? A radical paradigm shift. And sometimes that word and that phrase isn't really used properly, but it really is very much rethinking how nursing homes were and how they are now and should be, but doing so within the current regulatory structure and reimbursement structures. And it largely works. The how part of it is transformation that reflect 3 core values you'll see in the architecture, philosophy, and organizational structure. So I'll just show you a few slides and a few pictures of that. The first core value being real home. Every greenhouse home has between 10 to 12 residents. A sense of real home. I appreciated today earlier with Melissa, and we were talking, it's not home-like, it's home. And that is really creating an intentional real home. Warm, open living plans similar to the surrounding community, private rooms and bathrooms, residential finish, very intentionally intended to be a community. Another key element, the private bedrooms and bathrooms you see right there. Another key element is an open kitchen. It's open access to the elders at all time. Elders is a word when I talk about paradigm shift. There's a new terminology that goes along with greenhouse homes. Open access to the elders at all times, except the very busiest times. They can prepare food with supervision, and there's built-in safety features so that, of course, it's safe for the elders and family members to be able to participate and use the kitchen and create food and enjoy meals together. And then relatedly, another key element is the dining room, a central dining room right in the middle of the home, as you see there. Again, a very typical one. So the floor plan, oh, and I'm sorry, can't forget the central living room and hearth, this is really the hub of the home. There's the living room and the hearth so that there's a sense of, like in our own homes, a dining room where, and often a television, right? Like our own homes where people get together. So now the floor plan, what you see in the space in the middle, that is the convivial area with the hearth, the dining areas in the middle, and all the rooms are around the periphery. The second value is meaningful life, and it has to do with person-centeredness, just like where the culture change movement began, placing decisions about care directly with the elder as close to them as possible, really focusing on relationships and focusing also on quality of life and quality of living to supporting a life worth living with engagement, enjoyment, purpose, and continued growth. And then the third core value being empowered staff. The elder is the one who is at the center of the organizational chart. Is all about the elder. It's not about what works best for the staff. And the leadership style is very different. I'll show you a graphic of it. And basically it redefines the roles and responsibilities of all of the core staff so that the elder is in the middle and the care staff gravitate around the individual. You know, this is the typical organizational chart we see both in perhaps the places where we work and also in nursing homes. You've got the administrator at the top, you've got your director of nursing and other heads of different organizations, the next row, all the way down to the CNAs at the very bottom. I know if you're listening to this, you know it's the CNAs that are really the core people. And here, a traditional organizational chart, that's what that looks like. That's not the best way to promote best care. Instead, the redesign of the greenhouse model is very much, you see the circle there with the elder in right smack dab in the middle. I'll point out a few of the different components here. Those S's, Shabazz, the direct care workers, this is the thinking about people in a different way, not getting tied up in that old term nursing assistant. By the way, assistant really is a demeaning term, unnecessarily so. Shabazz means Royal Falcon. They are placed right around the elder in the care system. The administrator is called a guide. It is not an administrator who's directing the care that's being done, but the guide is available, the administrator is available to be a guide. There's also volunteers who are important that are, in this case, referred to as SAGE. And lastly, you see the clinical support team at the top. There is a clinical support team, but they are not on site 24/7. They're available, and often if a community such as is here right in Minnesota has numerous greenhouse homes, they might be in one of the other greenhouse homes as opposed to this greenhouse home at a given time. They are available, but they're based off-site. The first greenhouse home opened in 2003 in Tupelo, Mississippi. Again, Lois, one of the pioneers in doing research related to that. As of now, 401 homes, 35 states, 8 in South Australia. I need to move. There we go. Something had just gotten in the way of the screen, but I can see it now. So there is evidence of benefit, people in greenhouse homes. Privacy, dignity, autonomy, resident and family satisfaction. There is evidence that those all feel better in greenhouse homes. And I would say, I think we could all agree it is a feel-good model. There's no question about that. The concern, however, though, is has this been a practical model? And is it a practical model? And are there any risks involved? You've got that healthcare team, they're not on site the way they are in a traditional nursing home. That might not bode well for a person's physical status. And you've got the administrator who is more of in a supportive role. And perhaps you need to have more involved expert administration, if you will. So questions legitimately were raised about, is this a worthy model? If it's going to be worthy, it's got to be more than just a feel-good model. It has to more than just pass the sniff test, which I think we just said it did. What we really want to know is so truly, what is the evidence behind widespread adoption? Is this a model that is worth adopting? I will present evidence quickly in 4 different areas. I'll talk about the core principles. Is there evidence about those? I'll talk about fidelity. If you build a greenhouse home, if you develop it, will you have fidelity? Will it run the way that it's intended to run based on the model? Are the outcomes really better or at least as good? If quality indicators, the traditional nursing home quality indicators and healthcare utilization isn't as good in greenhouse homes as in traditional nursing homes, I think this is a non-starter. And then lastly, talking about that, I think we can't not want to ask about, so what happened during COVID in greenhouse homes? So again, I'll briefly talk about each one of these and then wrap up my talk, and then we'll get to hear some of the more on the grounds experience. I'll just let you think about this for just a moment, thinking about whether you think the literature supports, whether there's a good evidence behind having private rooms and bathrooms and non-institutional residential style dining and a universal role of staffing and elder-centered care with choice and control and engagement that is intended to be normalized. And by this, I mean the model initially was developed that you're living in a home. You are going to be doing dishes. You're going to be folding laundry. You're going to be cooking. At our homes, I don't know how many of us pull out bingo games, probably not very often. We've got active engagement and activities that we're doing that are more normalized. So I'll let you think for a minute what you think the evidence is behind these, and then I'll just show it to you. Quickly, why? So what's the evidence? There's also pros and cons. Evidence goes both ways often, but on balance, these are all benefiting greenhouse homes except for the last one. Physical structure, private rooms and bathrooms, absolutely better in terms of infection prevention and control, but there's a concern about social isolation, so you need to attend to that. Non-institutional residential style dining, yes, evidence people do eat more. However, there's also been some cases in greenhouse homes where having one table, if there was one elder that needed more supportive care or perhaps was having a bad day, it might be helpful in some cases to have 2 tables. Not totally separated, but in some cases, everything needs to be person-centered to the organization. Staff and universal role in self-managed teams, staff do feel more empowered. Families feel that there is more choice, but not all staff gravitate towards leadership. And it does take more time because those shabazim, they are responsible for everything in a universal worker role. Elder-centered care. Of course, we all, who doesn't want choice and control? But when we were doing the deep dive in literature to find this evidence, I found something that I think really resonated with me. Yes, choice and control are important, but predictability matters even more. I would suggest to you, if you can't necessarily decide who your Shabazz is going to be that day, but if at least you know you're going to have a Shabazz and he or she is going to be there at 9 o'clock, et cetera, et cetera, et cetera, predictability can be more important. And I don't think we study predictability. So I'd love to see that being something that's in the offing. And then I had already talked about this normalized engagement. And earlier today, when we had a wonderful tour of the local greenhouse home, I was reflecting that when the model started, we did think people would just automatically gravitate towards doing these daily tasks, but they didn't. You really do need in greenhouse homes someone who's facilitating engagement. And I remember the remark I made at that time was, it's not unlike those of us who have kids at home. They're not volunteering to unload the maybe yours are, mine aren't volunteering to unload the dishwasher. So I think in all cases, you do sometimes need to be able to facilitate people. Second area of evidence I'm going to talk about is fidelity to the core principles. I just have 3 of them here, but it's good to be illustrative. This was a study where we compared these 3 key principles in greenhouse homes to what's called the legacy home. Often greenhouse homes are built on a campus where there's still the traditional nursing home model. Not everyone can live in a greenhouse home. So we compared the extent to which these 3 examples were in evidence in the greenhouse homes. First thing, if you just look at the percents, in every case, the percent was higher in the greenhouse homes than in the legacy homes. But a little bit of a few stories to tell here. What you see is in the greenhouse homes, just type in open accessible kitchen, only 75% of the greenhouse homes of these 12 organizations we studied had it. So there was some fidelity, but not perfect fidelity, still better than the legacy home. Empowered staff, absolutely, that was a model that they were consistently able to employ. But look at meaningful life. It was very hard to be able to achieve, in this example, whether or not elders were able to bathe when they want. So I've got a couple of stories I'm going to share with you. All these studies, quantitative data, but also qualitative data, the stories that help explain things to us. So here's a few of the stories that we heard. This is one of the challenges about an open and accessible kitchen, family use. So if it's for their relative and other things aren't being prepared at the same time, that's fine. If they're in the kitchen while the Shabbazim are cooking for everyone, we have to plan it out. We need to make sure it's safe for everyone. Like with how things are cooked and textures, we have to follow our guidelines. So there are potentially some restrictions. And coming to empowered staff, one of the challenges in terms of universal workers. Our satisfaction with the food was not great because you have 19 and 20-year-old CNAs cooking. Not everyone can cook. And even just before we go to the next quote, even this fidelity idea, we know they're Shabbazim, but people still talk about it, CNAs. And in the greenhouse home today, these are elders, but I heard them being referred to as residents and in some cases patients. It's paradigm shift, very much changing our model. And then self-managed work teams, I think is a scary thing for some people. They think, oh my gosh, I have to fill these staffing holes. It's more time consuming than their other roles because of all the administrative components. And then the last story is an administrator who was talking about the challenge with meaningful life. And the administrator said, one Shabbazim came up to me the other day. She's been in the greenhouse home 3 years. She says it's like it is in the traditional nursing home. When a resident leaves, whoever comes in their spot gets the bath, right? I said, no way. He doesn't have to take the dead man's bath. That's not the way it works. I said, when does he want to bathe? And she said, well, I don't know. I haven't asked him. She'd been in the greenhouse home 3 years, right? I had an earlier conversation today. This is a terrific model. Even in a prescribed model, we continue to have work to do. Third area of evidence is talking about the outcomes. I had said earlier, and I believe it to be true, for widespread adoption, and if there's going to be more federal support, it's got to be more than a feel good. We've got to understand what's happening on the healthcare side. How is the health at least not being negatively affected by the fact that clinical staff aren't there all the time and the administrator is not there all the time. So this was a study where we compared 15 greenhouse nursing homes, matching them to 223 nursing homes, made sure that we really were comparing apples to apples in terms of how the communities the nursing homes ended up being similar, and then also making the residents similar in terms of the evaluations that were done. And here's what we found. Compared to other nursing homes and controlling for all those important differences, there was in the greenhouse homes a lower presence of bedfast, catheter, and low-risk pressure ulcer indicators, and lowered hospital readmissions. We know what a critical outcome that is in nursing homes, and decreased Medicare spending of over $7,700 or 30% per resident per year. So let's think about where that might come from. Where do those benefits come from? And then also where do the cost savings come from? Obviously, we would surmise hospitalization is a big ticket item, and so that is going to be a way to move towards having lower spending. And other projects that have already been done on care management, we see that better care management relates to lower hospital spending and fewer readmissions with the Interact and Evercare projects doing that. So the greenhouse homes, the results may be due to a similar process in which close contact with the Shabazim, coupled with this more person-centered approach in a conducive environment, helps you detect and communicate change in condition more quickly. So again, I got a couple of quotes for that. And this one might talk about how it is that consistent workers and person-centered care make a difference. So a physician said, I walk into a traditional nursing home and I'm talking to the LPN, who's gotten the report from the CNAs, who's gotten the report from the nurse, who's gotten the report from the nurse that was on before her. You only have to find the Shabazz to get all the information you need about a resident, how a resident is doing. And in the context of that, so not only is it better firsthand information and provided more quickly, but also there might be something about the environment. And by virtue of this being a small home, people are more often bumping into each other, if you will. So nurse practitioner said, I ran into an OT who said the elder wasn't doing so well, not progressing, having a lot of pain. So I made a suggestion. The OT said they already tried that and it didn't work. So together we agreed on a new approach. If that hadn't happened, it could have taken days to get there to that approach. Think about all the communication up and back. But you're in the same space, you talk, and you can move forward quickly. Okay, lastly, got to say something about COVID. We were very curious about what happened in greenhouse homes during the time of COVID, and also whether, when in the greenhouse homes, whether there was something different above and beyond just the smaller size of greenhouse homes. I'm jumping right to the chase here. The bars, those are the colors. The lilac is the greenhouse homes. The flesh color, if you will, is those homes of less than 50 beds. And then the turquoise is greater than 50 beds. And in every case, you see the benefit of the greenhouse homes. So the summative point here, the greenhouse homes differed significantly from traditional nursing homes with both less than 50 beds and more than 50 beds in both cases, the number of cases of COVID that occurred, and deaths amongst people with COVID. Pretty interesting. So how do we surmise that? Well, first of all, I think one thing that we've seen from these data is that they are beneficial beyond their small size. It could have been that there were fewer cases due to private bedrooms and bathrooms, fewer ancillary staff coming in and out, and fewer admissions. And then the mortality could have been due to those psychosocial factors, the feel-good factor that maybe we can't put a price on, but maybe we can. And I do have to put out this caveat here. There also could have been some inherent differences between greenhouse homes and traditional nursing homes. The residents do tend to be less diverse. They may have had fewer risk factors. And also, they tend to be more often to be not-for-profit, which also often have higher quality. Staff get paid higher wages, so there could have been fewer people having secondary jobs. But you know what? I don't know that that matters, because the point is they had better outcomes for whatever it is that's driving the greenhouse model. So in conclusion, from what the research tells us, some domains of quality of life and satisfaction are improved. The components of the model are evidence-based overall, and despite variable fidelity, it's not always going to be adopted and enacted perfectly. There are beneficial health and cost outcomes, because those data about those outcomes were found in homes that didn't totally ascribe to the model. But there's, of course, research challenges and other challenges. And one thing that I want to put forth about the resource source challenge, and I know my colleague Susan Ryan will be presenting shortly after Melissa, is that we don't have a strong evidence base just specific to greenhouse homes. There's not very many nursing homes that are greenhouse homes. There's not very many residents who are greenhouse residents. And then when there is information, the greenhouse residents, often those data are kind of lumped within the rest of the nursing home organization. So the conversation we had earlier today about really wanting a database dedicated to greenhouses would be invaluable. And I know Susan is working on a national level to do that. So with that, again, Joe, thank you for the honor of being here. It is really something that means a great deal to me. And I now turn this to Melissa Schneider from the Episcopal Homes to tell you what examples and what experience has really been from her part. Thank you again.
Yeah, thank you everyone for having me here today. So my name is Melissa Schneider, Chief Operating Officer at Episcopal Homes. So I'll share by telling you a little bit about us and what our experience has been running greenhouse homes. So the gardens opened in 2015. So we're in St. Paul, Minnesota. We are an urban model of greenhouse homes. So as you might picture greenhouse homes being a singular home next to each other, we actually have 6 homes stacked all on top of each other one by one. Because we're in the middle of the city, we're actually on University Avenue, just about 10 minutes away from us here at the University of Minnesota. So each of our homes has 10 elders in each home. And so for us, since opening our home in 2015, and to tell you a little bit more about Episcopal Homes, we actually have 2 nursing homes right on the same campus. So we have a traditional nursing home that was built in the 1960s, 131 beds, so large traditional model. And then we built these greenhouse homes in 2015. So we really can see the difference of that institutional model to the greenhouse model of care just right on our own campus. And for us, what we've really experienced is better quality of life outcomes, clinical outcomes, workforce outcomes, and financial outcomes. Starting with quality of life, for us, we look at data and a family satisfaction survey every year. And so as of the most recent survey data, we were in the top 7% of nursing homes in Minnesota for family satisfaction, trending higher in all 4 areas that they look at. So they look at staff care, food, staffing, and then the environment. So trending 10% higher in those first 3 areas, and then 16% higher in satisfaction with environment. Why I think that environment is so significant is when it comes to family satisfaction and families feeling comfortable visiting elders in nursing homes, having an environment that's conducive to that really combats some of that social isolation that I think you see from the nursing home environment. And I see that compared to when you think about a traditional model of care and family members coming in, you want to visit with your loved one, you're walking into a room that maybe they share with a roommate, roommates sleeping, roommates watching TV, you try to go to a common area shared with 50 other residents, right? That's what it might look like for a family member in a traditional home. In a greenhouse home, you're coming in and there's 10 elders. Speak up a little bit. There's 10 elders, so family members can come in, they can sit at the dining room and they don't feel like they're infringing on other elders' space. They feel like they can visit in a private room. They feel like they can walk into a kitchen. We had a family come this last Thanksgiving and cook an entire Thanksgiving meal for the household of their family recipes because they knew they could and they felt comfortable doing it. So I think that's the difference when it comes to satisfaction for families. And then with elder satisfaction, we trend higher in every single area again: dignity, activities, autonomy, caregiving, environment. And for our elders, a couple of measures that I pulled out, the dignity rating is really important to us. We know that people, when they end up in nursing homes, they feel like there's that loss of their dignity. They are completely vulnerable and, they're relying on other people. And so what can we do to change the model of care so that they do feel like they still have dignity? And the activity rating, as Dr. Zimmerman noted, we try to do more normalized engagement. And that really is a principle of the model. And I think it is interesting to show that we trend higher in activities, even as we don't fully invest in totally formalized activities. And for us, we found it's a balance. Do not try to take away bingo. We learned that. Bingo matters no matter what the model is. People want bingo. So we make that happen. But then we also do normalized activities where our elders maybe will go down to the courtyard and garden by themselves. And then we will actually use those vegetables to cook with them. And they can cook in our kitchen with those vegetables. So it's not that same structured, wake up at 9 a.m. First, we're going to read the paper. Then we're going to talk about the news. Then we're going to color, right? It's what do you want to do today? How do you want to spend your time? What matters to you? Do you want to go to the house next door and have coffee with a friend? Great, you can do it. It's giving that dignity to just decide, what do you want your day to look like? So really, and everything around that revolves around real home. So what does real home look like? Looks like hanging out with a friend, going with a friend to exercise class, maybe decorating the home for spring with those that live in the home with you to make it feel like your home. Clinical outcomes, as Dr. Zimmerman shared, we've seen a lot of the exact same outcomes that were in the presentation. So I think that's kind of cool to see for us, seeing trending 60% below the national average in rehospitalizations, 33% less antipsychotic use, reduction in pressure ulcers, And I really do believe it's the continuity of staff that contributes to these clinical measures. So when you think about rehospitalizations, I think that Shabazim role is really important to measures like these. So you think about, Mrs. Smith, who maybe has a routine every day of getting up at 7 a.m. and starting her day with coffee, right? That's what she does. Her Shabazim knows that's what she does. So on a Saturday, when she doesn't get up and she's a little lethargic, her Shabazz notices that and talks to someone about it. Like, hey, normally she's out. This seems a little bit weird, and catches something early that if that were a staff member that didn't know her, doesn't understand her routine, and they come in, her baseline is nothing to them. So maybe that goes on for 3 days, 4 days, 5 days until it's a case of pneumonia that was missed, that now dehydration, septic, and you're going to the hospital. So that continuity of staff for us with those clinical outcomes is huge. And workforce outcomes. So this is a really hot topic in the industry right now, and this has been significant for us with the greenhouse model of care. So our nursing staff turnover rate at the Gardens is 36.5% compared to the national average of 52%. And since opening the building, we have never used outside agency staff. So Clifton Larson Allen does an industry report every single year. And as of this most recent year, 71% of nursing homes had outside contract agency in their buildings. And so that means it's not their own staff caring for their elders. It's someone else who doesn't know them coming in to fill a shift because they just need it filled. So for us, we've never had to utilize that, which is really significant, I think, with all the measures you see across the board. And then something else that's really big in the news right now is the CMS federal staffing mandate that's coming down the pike for nursing homes. So what the new regulation is going to be is that nursing homes need to staff 3 hours and 48 minutes a day of direct care staff time. The national average right now is 3 hours and 47 minutes. At the Gardens, we have on average 5 hours and 5 minutes a day of direct care staff time. And so I think when you look at that, you're like, why wouldn't everyone do that? That seems great. Or how do you do that financially? And that really comes to that empowered staff model. Because as you saw that organizational chart, when you're putting the Shabazz around the elder and you're removing some of those layers of administration, you can afford to have more Shabazz, but only if they're empowered to do the work that you're taking away, because you can't just do it without having the culture. And so for us, yeah, that looks like a lot of training for our staff when they come in, and removing those layers of administration and putting the decisions where the decisions make the most sense to be made. I think there's a really good example that kind of mirrors off some of the stories that Dr. Zimmerman had shared. And one of those, we had a new elder that came and moved into the household. And normally what that would look like in a traditional nursing home is the director of nursing getting the clinical chart from the hospital, looking through those clinicals, writing a plan of care based on what the hospital's experience was for a week while the elder was there, giving that chart to a nurse manager, who then would bring that to the nursing assistants, who then will, okay, this is how we're told to care for the elder. And then that's what they do. So in this situation, someone new moves in, our Shabazz go and meet that resident. Hi, nice to meet you. What do your routines look like? Do you like to get up early? Do you like to sleep in? When do you like to bathe? Do you like showers? Do you like baths? And they actually talked through with that elder what they want their day to look like. And they wrote their own care plan with the elder. And I think our director of nursing cried the first time that happened, because it was so significant to say, in that traditional example, where is the elder in directing their plan of care? They're not there, right? It's a hospital worker's experience with them that's directing their whole plan of care. And so flipping that and having the staff empowered to do that, I think an interesting paradigm shift is that idea of thinking staff don't want more work. Like, we're giving them more work in this model than they're used to having. But when they are able to control the things that actually make sense for them to control, and they're not feeling frustrated by going through multiple layers of bureaucracy to get a change made, they're actually so much more satisfied in the work that they're doing. Another thing that we actually just started doing this last year, even after being open since 2015, was self-scheduling. So again, you talk about control and administration giving up control. That's a scary one to give up, because ultimately we're responsible for the care and that the care is there. But post-pandemic, flexibility, work-life balance is something that's really important right now. And healthcare has not really been able to achieve that. And so we brought that to the House, talked with the House about how that could work, and they made it work. So we had a Shabazz that agreed to be our scheduling coordinator and now works with her coworkers to schedule the staff for the House. And we had one Shabazz that had made a comment on the floor, like, oh, my daughter's birthday is next Tuesday and I work Tuesdays. I'm not going to be able to throw a party for her on her birthday. And our scheduling coordinator, Shabazz, said, you realize we do self-scheduling, right? Just don't schedule yourself. She was like, oh, this is amazing. I didn't realize that. So I think our staff, once they're in the model, that is why our retention is so good, is they start to realize how significant it is for them and how different it is than a traditional model of care. And so I think that question of, okay, based on that, can you actually have positive financial outcomes in this model? It seems a little bit too good to be true, right? So since opening, the Gardens has run at 96% occupancy or higher. And then currently 50% of the elders in the Gardens Greenhouse homes are Medicaid. So they are paid for by state funding. And I think that's a different shift for people as well. When you see a model like this and you assume, well, you have to be private pay to live there. And that has not been our experience. And for us, this is really important because we are in the inner city. And if we weren't able to take Medicaid, we would not be serving the population of the area that we are in. And so one of the big reasons that we're able to do that and it's financially feasible for us is that Minnesota allows a private room rate incentive where we get paid a little bit more for having private rooms. And so I think when you're challenging, state government or federal government on how do we push this movement forward, having those incentives, especially rate incentives for nursing homes to kind of capitalize on culture change is an important way to do it. So in 2023, the Gardens did have a 4% positive operating margin. Leading Age Minnesota, which is an association of nursing homes here in the state, pulled some data that in 2023, the average nursing home had a negative 1.58% operating margin. So you can see for traditional homes, like that's not sustainable. We're not at a pace where our homes are going to stay open, where nursing homes are going to be able to continue functioning. And so while 4% doesn't really knock your socks off, it's not really supposed to in the healthcare business, I think, right? We want to pay good wages and we want the money going back to our residents or our elders. And so I think this is a model that we've had a lot of success with. But that success doesn't come without challenges. So there are definitely a lot of challenges with staying on model and keeping integrity of the model. There is a huge leadership commitment to making this work. And we've even seen that in our organization where we've had years where we really struggled to do the greenhouse model of care. And those are the years our financials were the worst, because we started to get off model. We started to layer in administrative staff to follow up with things. And then all of a sudden you've got all these extra FTEs and your financials are going down. And so it's really that commitment to education and staying on model that you have to have for this to work. Another challenge that we face is being an innovative model in a traditional regulatory landscape. So as we're elevating those Shabazz and as we're empowering them to, tackle the challenges of nursing homes, there is still 863 pages of federal regulations to comply with. And so how do you ask a Shabazz who's now in charge of care, who's now in charge of scheduling, to also be aware of 863 pages of different regulations that we can get in trouble for if we're not on top of? And so I think as care changes, our regulations need to evolve with that. And sometimes I think our regulators get so obsessed with the idea of what the regulation is that they forget that the point of the regulation is quality care. And so how do we think about that differently and how do we regulate differently to ensure that we're getting the quality of care that we want? But for us, we found that despite the challenges, despite, workforce availability, all of it is ultimately worth it to have the quality of life that we're able to see. And, someone like I'll share, a resident Erna who just turned 109 this year, who's able to hang out in our common spaces with her family and feel like
just my hand. Okay, the next. We're trying to.
And I think from here, I'll be turning it over to Susan Ryan.
Hi, everyone. I can't turn my camera on. Happy to try to do that if I can, if the host will let me. And I guess I'll go ahead and get started, and you can, I guess, look at the picture of me. Well, first of all, I want to make sure everybody can hear me. Are we good? The person at the mic, if you can just kind of give me a thumbs up if you can hear me. Okay, awesome. All right. I just want to acknowledge my fondness for Dr. Rosalie Kane. I never had the privilege of meeting Bob, but I can't tell you how much I appreciated my conversations with her. I certainly appreciated her research and that of Dr. Lois Cutler, who I understand is in the room today, and certainly what Dr. Sheryl Zimmerman has done with us over the years. It has been such a gift to be able to work with these folks to really establish what are we learning from research? What can it teach us as we go forward? So I thought what I would do today, I have been part of the Greenhouse Replication Initiative for over 16 years, and we are a bit over 20 years of greenhouse living. And so I thought what I would share with you today is just kind of my reflections on what have we seen over 20 years of greenhouse living. So on the next slide, I have kind of indicated that we're going to start with why. And why greenhouse? I think working with greenhouse has really been the pinnacle of my career, and I would call it the pinnacle of culture change. But more than that, if I could, I would take you on a seeing is believing visit into a greenhouse home. So I'm going to have you go to the next slide and play a video that will take us into a home, and you can hear a family member.
It was a long journey for my family, and she lived at home with her diagnosis for about 4 years. And the last 2 years that she was at home, she sat in her chair and she didn't talk. You could try to talk directly to her, and she would sometimes talk back to you, but she was really not having any conversations. She got to where she would get up and go change clothes multiple times a day, but she had no quality of life. There's this awesome new concept that we have here in this little community. Let's try. Within that first week, she calmed down. She knew where her room was, so she was already familiar with her house or cottage that she lives in. The staff, and they do this with everyone. I feel partial because it's my family, but they really took to her and made her a part of their family immediately. I mean, the first night she was here. So as that week went on, they had her playing the piano again. They had her baking a cake. She had not baked or cooked anything in, even more than 2 years, probably 5 or 6 years. She had not been in her kitchen. And they had her baking cake, and she was settled. And so a month passed, and then 2 months and 3 months, and now she's been here for over a year. She hit her year mark in January, and she has quality of life now. It's like a complete turnaround from who she was. And we had a Shabazz who wasn't working in that house, but she had just had a baby. And so she had brought the baby up here just to show the baby off and visit. And she took him into my mama's house, and my mama just instantly fell in love. She wanted that baby, give me that baby. And she held him and rocked him and just sang to him. And just, you would have thought that was her, with her sons when they were babies. The way that she was able to sing a song, it was like that baby brought back more of her. And so the Shabazz was so great. She just let her hold on to that baby for a really long time. I mean, it felt like an hour or more. And they just rocked and singed, and that made her entire day, you know, for what she would remember. But it was just incredible how, because you can bring babies in and small children, and it does. You see that with dementia and Alzheimer's, like it'll trigger something. And it did for her that day. And that was her baby boy, and she was just rocking and singing. It was awesome.
Yeah. Well, that's why they do sometimes. Yeah, you and
So I think you can see from that, the power of normalizing our environments. And next slide, you can get us there to that next slide. But
So
then
it-
once, there we go. Relationships are the root of everything that we're talking about. That idea that we're growing people, that we really, even somebody with advanced dementia who was really not communicative when she was at home, we had some research that showed us about 85% of those living in greenhouse homes had mild to severe cognitive impairment. So it's a model that when we normalize our programs, our environments, and really create those engaging opportunities to be for elders to be with children, that those normal opportunities once again, and to be in relationship, that's the root for a healthy culture. And that is really what is at the root of this model. On the next slide, when I think about my why and why I think hit it again, there we go. Why I think greenhouse to me really makes the difference. And you see the reputation, it's really interesting, especially with the research of Dr. Zimmerman during COVID. That research was heard around the world, literally. We had folks reaching out to us from all over the world about the COVID data that really kind of put the efficacy around the small house environment. And certainly that reputation, that research is what really has characterized the greenhouse model. It's really looking for the evidence base and how we can take the research that we have gained from all the esteemed researchers that have been part of taking a look at the model and how that has informed what we do by way of education. And Melissa had such wonderful things to talk about that really validated some of the research that she has found as well, some of the data points that she has collected. The peer network. I think this is what the strength of partnerships and really being a part of something. You're not in this alone. I often call greenhouse adopters my community of thought leadership, and really understanding who's out there and what are they doing and how are they living the model? What are we learning from them? And how do we collectively apply our wisdom and our learnings to keep growing and evolving? Education. I used to think that education was our secret sauce, and Melissa made some reference a bit to the education that, how important it is to make sure that your teams are equipped with the education and the resources that they need, not just to open the homes, but to really ensure that once they are open, to sustain the homes. Project management. I began my career as a project coach and really was a guide on the side, working with greenhouse adopters to really help that organization implement the greenhouse model. It's not just do the education and you're done, or here's the cookbook and you'll know what to do. But it really, what are those policies and procedures that need to shift and change to operationalize it? When Melissa mentioned that, this is a very innovative model and a bit of a regulatory landscape. And so what does it look like? How are we meeting or exceeding the intent of those regulations? What does it look like? And last but not least is sustainability. And it was researchers that have researched greenhouse that helped us develop a tool that is administered annually the Model Enrichment Resource Integrity Tool. It's a model fidelity tool where we're really assessing and looking at model fidelity. How well are we living those core values? And what are the organizational outcomes that are being generated? So on the next slide, we're going to go through these pretty quickly because some of these things we've already talked about. The model is adaptable. This is a single family home. So from a physical design perspective, on the next slide, you will see urban models that there's a 6-story building in Boston up on the upper right. You'll see that's an elevator bank to the left, and that's Pompano Beach, Florida in John Knox Village down there. That's a 7-story building. They've got 12 homes at the bottom, and up the top, they've got 10 homes. On the next slide, we've got some greenhouse homes that are more in the suburban areas, 3-story buildings where there's a greenhouse home on each level, and then a 2-story where you've got a greenhouse home on each level. Next slide. I think the other thing that was really a part of our community of thought leaderships, they said to make these homes financially viable, we want to incorporate 30% Medicare into our payer mix. So we will have long stay home, which is what we thought. That's what greenhouse is for, long stay people. It's home, it's real home. Why do we need to do rehab? Well, rehab is an amazing experience in a greenhouse home. Dedicated therapists coming into your home. And so now more and more of our greenhouse communities are opening homes that are solely dedicated to short-term rehab so that you're able to do functional rehab within that home. On the next slide, the Greenhouse and PACE, the Program for All-Inclusive Care for the Elderly. This is an innovation in downtown Detroit, where the PACE of Southeast Michigan, they partnered with the Presbyterian Villages of Michigan. And what they said is that they really believe that about 7% of PACE participants who all need a level of nursing home care, but about 7% were actually being housed in long-term care in traditional nursing homes. And so what they said, we believe that if we put them in a greenhouse home, we will yield better outcomes. And that all-inclusive rate that we have for PACE, we believe we can control for hospitalizations and other clinical outcomes much better. And so in fact, they took PACE participants from local nursing homes that were having PACE services during the day, but were living in a nursing home. They put them into the greenhouse homes that you see here. And so in fact, they've got 2 homes, a total of 21 people, 10 in one, 11 in another, co-located with their PACE site. So during the day, they go to the PACE site and this is their home. And it's so incredible to talk to the people that are living in that home. On the next slide, you're going to see how this model has adapted to meet the needs of different populations. This is Bonnie, who is in Boston, living in a greenhouse home with others that are living with multiple sclerosis. On the next slide, you will see a gentleman living with ALS. And there are 2 homes in the greenhouse community in Boston for supporting people that are living with ALS. To the acuity level of those living in greenhouse homes, those homes have, right now, I believe, 4 that are supported by ventilators. So from an acuity perspective, the homes work, they're adaptable. And for the same acuity that you're in a traditional home, these are things that can be done in a greenhouse home. On the next slide, when we think about different licensure and organizational types, we are about 80% of our greenhouse homes that are licensed as skilled nursing. 18% are licensed as assisted living. Assisted living is predominantly a private pay model. I do happen to know that in Minnesota, there is a Medicaid waiver, so there assisted living can be done in assisted living to receive Medicaid reimbursement. It's one of the few states that have that as a provision. It's home for life, and so greenhouse homes are, and so we really want to try to ensure that this model works with current reimbursement structures, which is why so many are licensed as skilled. We've got about 2%, and they are located in Washington State, who has an amazing adult family care model that allows for Medicaid reimbursement for adult family care. And they've got 2 homes of 6 people in each home. So it's a very small group home type setting. You can see that overwhelmingly we are not for profit, 10% are for profit. I will tell you though, our largest operator of greenhouse homes happens to be a for-profit operator in the state of Arkansas. And he has about 55 greenhouse homes across the state. On the next slide, I think the question is always asked, but are these homes viable? And certainly Melissa made a beautiful case for their personal experience. We did some research during COVID, and we discovered that when traditional communities, the average was $276 per day, cost per resident per day. We were 261 cost per resident per day. We took a look at food cost, and the food cost on average was a little over $10 a day in a traditional building, but for greenhouse homes, a little over $8 per day. So when you think about the why behind that deep knowing, those relationships, when you know who a person is, what's important to the person, what do they want to eat, it's not oatmeal for everybody as an example, but you're better able to really address those unique preferences. And you're able to really control for leftovers, what you can do for leftovers, what you can do if somebody is, experiencing some weight loss, you can not have to use so much supplement. Supplement usage is costly. And we found much less supplement usage in greenhouse homes. And you're able to really find something that is going to suit that elder's needs. On the next slide, I think another big costly center, and this is where Melissa certainly validated this point as well. It's probably a little hard for you to see the actual numbers, but we took our merit data that I referenced earlier, and when certified nursing assistant turnover rate was 129% nationally for traditional buildings. For our greenhouse shop Azim, we were at about 33.5% turnover. For registered nurses nationally, it was close to 141% turnover. For greenhouse homes, it was 63.2% for RNs. For LPNs, it was 114% turnover and 41.6% for LPNs in a greenhouse home. So once again, labor being one of your most significant cost centers, you can see how to achieve financial viability. It's really controlling for costs like this. On the next slide. And it really gets to where I started with the why, and that is relationships being the root of a culture, and really valuing the people and growing the people that both live there and the people that work there. It's that philosophical shift. Sheryl called it a radical paradigm shift that really embraces whole people, people that are valued, people that often are marginalized, but people that are truly valued here. So in the next slide, this was I read a book during COVID called Compassionate Leadership. It was written by Dr. Michael West out of the UK. And I read this quote and I thought, this is really, it's all about greenhouse. And it really is that new era that is upon us that really is driven by connecting people to their purpose, where value lies in our ability to contribute to something greater than ourselves, to grow as individuals, and to build community. I think it is such a nice summation for greenhouse and its philosophy of growing people. On the next slide, we can call this opportunities, we can call the challenges, and then the opportunities that are there. I always tend to think, but what are the opportunities? Are there challenges? 100% there are. So on the next slide, when I think about the greenhouse model in my reflections, one of my mantras outside of it's all about relationships is it's all about leadership. It's really leaders that are driven and leaders that create the collaborative, coaching, compassion cultures that enable the development of deep knowing relationships that really are meaningful, and not just meaningful to elders, but empowering and meaningful to the staff that are there, where staff are able to grow and develop new life skills just as elders are as well. So what concerns me is CEO turnover rate. As an example, Steve McAlilly, the CEO of Methodist Senior Services in Tupelo, Mississippi, he went first in building the first greenhouse homes in Tupelo. He's retiring next year. In addition to him, there's a handful of other leaders that will be retiring among greenhouse homes. But when I think about the landscape of CEOs in senior living, I found some research, this was 2018, 70% of not-for-profit CEOs will retire in the next 10 years. And that was 2018. And so when you think about that and how COVID has exacerbated or fueled kind of what they called the Great Resignation and CEOs sometimes taking early retirement. So really thinking about the role of leaders in creating these cultures and the reality that there's a big shift in turnovers, both some at greenhouse homes because they're retiring, and certainly in the senior living landscape. So really addressing how and where to find those leaders. On the next slide, I don't know how much you're seeing this across Minnesota, but skilled nursing closures. I was in California last week at the Leading Age California, and I was appalled to hear of how many closures there are, even within the not-for-profit landscape. In fact, it's a lot of for-profits that are purchasing or acquiring these skilled nursing communities. And COVID obviously was the fuel. I just read of somebody closing their community, a not-for-profit in Rhode Island. I happen to know the CEO of that organization and reached out to him. He said, the reimbursement, I just can't make it happen anymore. It's a traditional structure. He had wanted to do greenhouse. He said, I just couldn't keep us alive to be able to make a shift there. On the next slide. In addition to that, and you heard certainly Melissa talk about this, it's workforce shortage. Greenhouse is not immune to trying to find the workforce that we need to really be able to address the upside down, the inverted pyramid that we're seeing. There are fewer people, that are going to be able to really support this work. And so it truly is a challenge that we're going to have to address. On the next slide, and this is something that that Sheryl alluded to, that said I would talk about it, and I absolutely will. I am grateful for the research that has been done on the greenhouse model. The greenhouse model has been perceived as highly prescriptive, highly rigid. I have talked to numerous people, and I have to admit, I was one of those at an organization that felt greenhouse was too rigid and prescriptive, and we were a do-it-yourselfer. We did it ourselves, and we adapted what we had seen at the greenhouse model back in 2005 when we visited to 16-person households. And we did not license it as skilled nursing, we licensed it as assisted living. As an example, I was but one of many organizations that have done similarly. So it is time, I believe, that we expand our data set, that we really look at what really matters to generate the outcomes that we would expect to see. And there is variability even within the prescriptive greenhouse model. But what really matters? And let's study a bit of variability. Let's study the 16-person models. Let's study those other places and see who's generating what by way of outcomes. And how then do we incentivize what we want to see? I believe incentives matter. And I'll go to the next slide and try to wrap us up. I think it's time that we amplify our voice to have greater impact. I believe, as an example, the New Jersey, there was a task force for long-term care quality and safety in New Jersey. I just read the report that was released in April, and they have recommended incentive for the greenhouse small house, a demonstration pilot to really study and show what really can happen in New Jersey. Ohio and Arkansas, they have increased their reimbursement rates, incentivizing private rooms. And I was happy to hear Melissa say they have done that as well in Minnesota. And so we need to incent what we want to see. And then from a bigger vision perspective, and Sheryl has been certainly part of the conversations I've had in the formation of an international household consortium, where we are really looking at a small house model operated by Hammond Care in Australia. And we've talked about how do we compare research of the greenhouse model and Hammond Care. And then there's another small house model in the UK that is a part of this consortium. And how do we really study each of our small house models? And once again, trying to say, let's take a look at, where our data differs, what really matters though in generating these quality outcomes. It is, I believe, the moment for the movement. And on the last slide, it is a moment where we must rise to the challenge of changing organizational and societal cultures to value every human equally and to ensure there's equity and care for all. I thank you for this opportunity, and I'll turn it back to our host.
Well, thank you. Well, thank you so much, Ashley, I want to thank Dr. Zimmerman. I don't have time for question and answer, but I thought we could do. And we're going to do is we're going to flip-flop between in-person questions and those online. I know, Alicia, for those of you that are online, if you have a question, please utilize the chat and or Q&A function in the webinar so you can ask those questions, and we'll have Alicia and or Ashley speak them. Otherwise, I think I'm going to take the privilege to start. And I think you're probably going to anticipate this question. And Sheryl, when you're ready, you want to come up, or Melissa or Susan, if you're hearing us online. Which is, this has all been great. Clearly, you have the data to suggest that this could be a viable model, a model that has positive outcomes. So why hasn't it been scaled? Why hasn't it been disseminated? Why don't we see more green homes? And I'd like to hear from Dr. Zimmerman, Melissa, and or Susan, why haven't we made more progress in dissemination? Susan, did you want to start that online? Good idea.
So I think you asked me to talk about why it hasn't scaled. Is that correct?
So
we can try this one too. Should we turn that one off?
yeah, maybe turn it.
Let's see. Well, same difference. Okay. Susan, the question was, what are you?
Okay.
It's not better.
Anyone have any ideas? I'm willing to.
Susan, could you talk about why it hasn't scaled?
Yes. Can you hear me? I hope you can.
Yes, we can.
Awesome. here's my thought. I really believe that there has been a lot of misperception about the financial viability of the model. It is assumed, and I've had many people, architects being one of them, tell me, well, it doesn't work. It just, you can't make it work, or I'll build you a small house, but you don't need to go through all of the work that greenhouse does. I think the other big thing, and I have said this many times, I think sometimes it's complacency. I think they're oftentimes, it's good enough. Our census is good. We're just not motivated we don't really feel the need to be able to do uh, something different. And I would argue our good wasn't good enough. And COVID, I think really kind of shone a light on that. But I keep hearing our providers just say, it's time to get back to normal. We've got to get back to the status quo. Oh, occupancy is rebounding. And so there's just this preoccupation with the status quo. We want to do what's comfortable. This isn't easy work to do, and it's not easy work to sustain. It takes investment. I do believe that incentives could help to really create the change that we want to see. I do think incentives matter. Arkansas and Ohio is where our largest concentration of greenhouse homes are. Actually, Mississippi, their Medicaid rate is a very generous rate. Arkansas and Ohio have incentives for the reimbursement rate. I think the other thing is the misperception on regulations that, well, the regs won't allow us to do this. And we have certainly worked with 35 states, and we're working with another handful of states to do a review of regulations. And there's really nothing in regs that would not preclude the adoption of a greenhouse model.